Hello, my name is Cassandra Romas and welcome to 30 Medical Minutes. Many people as they age have difficulty performing daily tasks or experience changes in the way they normally behave. This is often seen as dementia. While such situations are sometimes impossible to explain, the cause may be an injury or a medical condition. Neurological diseases such as Alzheimer's or Parkinson's disease may be involved, or it may be the senility of old age. Our guest today is Michelle Papka, Ph.D., a neuropsychologist who specializes in evaluating and treating adults with a wide range of cognitive problems. Dr. Papka is a private practitioner at Overlook Hospital in Summit, New Jersey. She will explain the difference between dementia and senility. We will learn about symptoms and available treatments. Much work has been done to find ways to assist patients to function more effectively in daily life. The result of multidimensional evaluation and treatment is also vastly important for caretakers and family members because it improves their ability to cope with the frustrations of caring for a patient with dementia. And now let us welcome Dr. Michelle Papka to 30 Medical Minutes. Welcome, doctor. Thank you so much for joining us today.
Thank you for having me.
Dr. Papka, could we start off by learning a little bit about yourself and your practice?
Sure. I'm a psychologist, and within my private practice, which is located at the Atlantic Neuroscience Institute at Overlook Hospital, I provide services in neuropsychology and also psychotherapy, and I'm also an active researcher.
Okay, very good. Now, you mentioned you're a neuropsychologist. I would like you to explain to me and to our audience exactly what a neuropsychologist is.
Thank you for the opportunity to explain that, because most people don't know what a neuropsychologist does. So neuropsychology is the study of brain-behavior relationships. And in clinical neuropsychology, we utilize the information that we have based on research of the relationships between brain and behavior. And when a person starts to show changes in behavior, personality, or cognition, which simply means thinking or knowing, we utilize different kinds of interviews, scales, and standardized testing to try to help understand what the problem is. We try to characterize what is happening with the person, what might be responsible, what diagnoses might be suggested, and then also to suggest recommendations for treatment.
Okay, so the advantage of having someone coming to visit you is that you come to an understanding of what they have and therefore can cope with life. Is that what you're saying? There is an advantage, obviously, to meeting with you and having this evaluation done.
There are numerous advantages. For one, a neuropsychological evaluation is a very comprehensive evaluation. It takes many hours, actually. So usually when a patient schedules an appointment with me, I have them fill out various forms and send me their medical records before they even come and see me, so that when they do come to see me, I have already reviewed some of their medical history and social history so that I have a good understanding of what's going on with this person and why they're seeking an evaluation. I will spend often an hour or more meeting with the patient and also any family members who might like to join them, and then I will do in-depth testing of cognition of things like memory and language, attention, visual and spatial skills, skills involved with decision making and planning. I will also do an in-depth evaluation of other kinds of symptoms that may be affecting this person, things like depression or anxiety, agitation. And once I'm done with the testing and the patient and their family member leave, then I'm left with the task of putting all of this information together, also collaborating with other physicians. I'm part of a multidisciplinary team of other kinds of doctors like psychiatrists, neurologists, general practitioners. And eventually, I will have the patient and the family member come back, and I will go over with them in detail the results and what my impression is, what do I think is going on, if anything, and what do I suggest to do about it moving forward.
Wow, that is a huge responsibility, and obviously it's a very involved process that you undertake here. And I'm very glad to hear that you use a team approach, not just yourself and your diagnostic testing, but you're reaching out to other physicians and to rule out, I suppose, other medical conditions that might be causing some of the symptoms. And we'll talk about those symptoms in a second. In the introduction, Dr. Papka, I mentioned dementia versus senility. Why don't we get to the point of understanding what is dementia and what is senility? Can you define those two for us?
That's a very good question as well. So earlier I had said that cognition is kind of this fancy word which means thinking or knowing, refers to our thinking skills. And dementia is a word that is used to describe global cognitive functioning. So dementia occurs when a person experiences a decline in different areas of functioning, usually including memory and at least one other area like language or visual skills, spatial skills, skills used in decision making. Dementia is progressive, which means that there's continuous decline. And the decline has to represent a change from a person's baseline, and it also has to be significant enough to interfere with daily functioning. So just forgetting where you ate dinner last night and not being able to come up with the name of that restaurant or the movie that you saw last week is not necessarily a sign of dementia. The impairment has to be significant enough to interfere with daily functioning. The difference between dementia and senility is probably just by name. We don't really use senility anymore. I think that was a word that had been used years ago, where people would refer to older people as being senile, but I think probably the word dementia has almost replaced that, and we have very specific criteria for diagnosing dementia.
Okay, so senility is a word that's passé.
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 Right.
We will not use that anymore.
Okay.
But dementia is a very serious concern where, as I'm understanding it, a person's ability to function in the world in the daily life is impaired so much that they cannot work well, function maybe even safely in their own homes, and that is obviously a concern where at a certain point caretakers might have to come in. So you've described the process that you use to evaluate whether somebody has dementia or not. Somebody has referred a patient to you. You first evaluate them by having them fill out a packet, I think I heard you say, with all this information, and afterwards you meet with the patient and or family member, and then you meet with the patient, and the third step, privately, where you do a battery of tests. Why would somebody want to seek your attention? What symptoms do these patients show that make it severe enough that they should seek your advice. Can you repeat what some of those symptoms are, please?
Well, some of the things that either the patient themselves may notice or people around them may notice, like family members or other physicians, would be things like memory impairment that seems a little more concerning than the daily kind of forgetfulness.
Like where did you leave your keys? That doesn't count.
Well, it depends how frequently you don't remember where you left your keys and if it prevents you on a regular basis from being able to get to where you need to go.
Okay.
So other things that might put up a red flag and lead to an evaluation would be difficulty paying bills. So if a person who always paid their bills on time suddenly now is missing payments, overdrafting their banking accounts, even various kinds of social withdrawal. So a person who may have been very active who is now starting to stay home more or not showing as much interest in things may put up a red flag that something may be going on. Sometimes patients notice these things themselves and express some concern about it, and other times the patient may not feel concerned about it, but the people around them may feel concerned about it. And the level of concern does not have to be overly severe to warrant an evaluation. I always say, if in doubt, check it out. The most you have to lose really is the time spent on the evaluation, but then it provides a lot of really very helpful information.
Okay. Unfortunately, I've had some experience with people who've indicated those type of symptoms. I've noticed repetition. You mentioned language earlier. I've noticed that somebody could be asking the same questions over and over and over again, and at first one answers the question with a goodwill, but I can sense that the person who's being asked the same question over and over again might get frustrated and or annoyed or even angry. Do you see that at all?
Yes, absolutely. And that's another reason why seeking medical attention for these kinds of problems is so important, because whenever we treat somebody with dementia or Alzheimer's disease, really we're never just treating the patient, we're treating the whole family unit. And caregivers, and I want to say something about caregivers because there are different levels of care that one can provide, and because dementia is something that's progressive and it's also insidious, which means it kind of creeps up on you. It's not that all of a sudden, one day, all of these abilities have been gone. It is slowly progressive. So when a person is first diagnosed, if they're diagnosed early on, there likely are many things that this person will still be able to do independently and should be encouraged to do independently. So getting a diagnosis is not, a sentence to kind of stay home and have somebody take care of you all the time. But the level of care that's needed, and also the changes that occur and the anticipation of change is very difficult to deal with oneself. It becomes very overbearing. And so by a patient getting a diagnosis, it also opens the door to all kinds of support, resources, help, and recommendations that might not otherwise be received.
Okay, so that is one of the reasons why somebody would be coming to you seeking help, because if with that type of diagnosis, then you have other opportunities to expand the area of care and consultation and just maybe some comfort knowing what the problem is. What causes dementia? And I'm not going to use the word senility. What causes dementia, doctor?
Well, there are different causes of dementia in the elderly, and the most common cause of dementia is Alzheimer's disease, the one that we hear the most about. There are other things that can cause dementia as well, Sometimes Parkinson's disease is associated with a dementia. There's a dementia called dementia with Lewy bodies. There's frontal temporal lobe dementia. And without getting into too many details about each of them, it's important to understand that the definitive diagnosis of any of these dementias is based on what is actually seen in the brain under a microscope. So in Alzheimer's disease, for example, what is seen in the brain under a microscope are plaques and tangles. And a definitive diagnosis really can only be made by way of autopsy, where the plaques and tangles per microscopic field are actually counted. In something like dementia with Lewy bodies, you'd see something else under the microscope. So the way that these diseases get categorized is by the neuropathology, what you actually see in the brain. But clinically, we have criteria that we use to make the diagnosis in life. And with Alzheimer's disease, for example, we know that when we use our clinical criteria, that we're correct about 90% of the time.
Okay, so Parkinson's is one of the causes, but mostly Alzheimer's. And it's something that most people never heard of Alzheimer's maybe 20, 30 years ago, and all of a sudden you hear Alzheimer's being mentioned all the time.
Mm-hmm.
What is the reason for Alzheimer's becoming so prevalent? I mean, it's just every place you hear of elderly people coming down with Alzheimer's. What's the reason for that?
Well, I think there are multiple reasons. One is that as a population, we're living longer. So as we're living longer, more and more people are also going to be getting age-related dementias like Alzheimer's disease. In the population age 65 and older, somewhere around 15 to 20% of people in that population have dementia or Alzheimer's disease. And by the time we're 85 and older, the percentage is about 50%. So as people live longer, more and more people are being affected by Alzheimer's disease. I think the other thing is that over the past few decades, there has been so much research in the field of Alzheimer's disease. So as we know more, more gets into the media, and there's more exposure about the disease. And I think the third thing, which is really very positive, is that more people are starting to feel comfortable talking about it. So especially in older generations where people may be less comfortable talking about illness or disease, you know, Alzheimer's disease is this bad word that nobody wants to talk about or hear, but we should be able to talk about it like we talk about diabetes or any other medical condition. So I think that there are multiple reasons for hearing more about it.
Well, that's very good, and that means that there must be something that can be done about it. So there's there's treatments available, is what you're implying. And are these treatments there to eliminate the problem? I don't think so, but are there treatments out there that can alleviate some of the symptoms, doctor?
Yes, so we have multiple medications that can be used to treat Alzheimer's disease. And while these are not cures, they do help to stave off some of the symptoms. In addition to the medications that are on the market specifically to treat symptoms of Alzheimer's disease, there are also other kinds of medications that can be used to help treat some of the symptoms that may occur with Alzheimer's disease, like depression or anxiety, hallucinations, delusions, sleep disorders. In addition to the available medications, there are many medications that are now being tested for the possibility of treating Alzheimer's disease. So another option would be to be involved in a clinical trial. And beyond the pharmacological treatments, there are also many non-pharmacological approaches that can be utilized to help treat some of the symptoms and to help improve the quality of life of the patient and also their family members.
So could you list what some of those non-medical treatments could be?
Sure. So some of what we can do is to, number one, help really maximize a person's level of functioning. So getting a diagnosis of Alzheimer's disease, as I said before, should not be an invitation or a sentence for a person to stop doing things that they enjoy doing, that they're capable of doing. We can help the family devise a plan for realistic functioning. And I've seen this work both ways, where sometimes family members will push a patient to do something like a crossword puzzle, for example, and if only this person would do the crossword puzzle, that would help maintain their brain functioning. And that really may or may not be true, and it never really results in anything positive.
You're saying that if a person or a patient never liked doing crossword puzzles, don't force them into it. But if they like doing something else, encourage them to continue doing that. Do I hear you say that if somebody has a diagnosis of Alzheimer's, that many people just like give up and like life is over and everything like that? Do people come to you with that dramatic type of response to hearing about their diagnoses?
Sometimes yes. And so part of what we try to do is to help that person and their family members cope with the situation and understand that if they came to me today and got this diagnosis, when they walk out the door, their life is no different than it was when they came in. So we want to use the diagnosis and the diagnostic process to help provide additional supports, information, and hope rather than the opposite.
So what you're saying now is that if the patient and the family support team understand what is coming down the road, with that understanding, they will be a little bit more tolerant of the repetitive questions or the memory loss or the inability to be able to get from one spot to the other. They would be far more, I don't want to say cooperative, but maybe compassionate or something, so that they will be able to support the patient, but also feel better amongst themselves. Because what I hear you saying is that the caretakers is a very important component, and not a victim of the disease itself, but a team member of that patient as well, right?
Absolutely, absolutely. And also the caregiver is being affected too. So the caregiver needs nurturing and treatment and help just as the patient does.
Is there anything anybody can do to prevent Alzheimer's or this memory loss situation from coming on?
Well, unfortunately, we don't know ways to fully prevent Alzheimer's disease or dementia, but we do know that there are certain things that are associated with higher risk factors for developing dementia and Alzheimer's disease. So, for example, maintaining a healthy lifestyle, eating healthy, exercising, higher levels of education, overall general good health. So reducing things like heart disease, vascular disease, other kinds of brain injuries or brain diseases, all of those things would lower our risk factor for developing Alzheimer's disease. So we can't prevent it, but we can do things throughout our life, not just when we're older, but throughout our lifetime to help lower our risk factor.
Okay. Eating well, exercising, reading, doing whatever educational, intellectual things you can do will keep the mind, so to speak, healthier and stave off those symptoms. Before we leave, Dr. Papka, I would like to visit the word research, clinical research that you mentioned. Can you talk to us a little bit about the hope with clinical research involved with that emanates from clinical research?
Yes, and this gives me an opportunity to mention that I have recently developed a private research program. It's called the Cognitive Research Center of New Jersey, which is located at Overlook. And we are a research program focused on clinical trials of Alzheimer's disease and dementia. And there are many, many new treatments that are coming down the line being tested for Alzheimer's disease and dementia. And now within our community, there is a site available to do that.
Okay. So this active clinical research is going on right here out of Overlook Hospital. Are there any specific needs or requests that you have from the general public?
Yes, I think that it's important to recognize that if we want a cure for Alzheimer's disease, then we need research. And the two biggest obstacles to Alzheimer's research are funding and also participation, people being willing to participate in clinical trials. So I think that if anybody is interested in participating in a clinical trial or even just wanting to know more about it and then to make the decision as to whether or not to participate, I would encourage them to contact us, and we would be happy to provide information about the trials we're conducting.
Well, Dr. Papka, if I could kind of recap everything that I've learned from you today, I would say that dementia is more prevalent today because of an aging population that lives much longer and not falling victim to other illnesses such as heart attacks, et cetera, that with the current treatments and, well, emanating from all the research that's come out, that there are medications and non-pharmacological treatments that can be done to alleviate some of the symptoms and allow for better functioning within the daily lives, so that people, even if they are diagnosed by you with Alzheimer's or dementia, can find a way of still living, functioning, and not being put in a negative situation where people are frustrated with them, angry with them because they lose their keys, or they repeat things, or they're showing signs of depression, or are retreating from a social world. Not only have I heard you say that, I've also heard you say that if people are living healthy lives and exercising, that there's a very good chance that this could be prevented or put off to a later stage in life. Have I summarized a lot of that for you, Doctor?
I think you've done a great job.
Okay, well, we want to thank you so much for joining us today on 30 Medical Minutes, and we hope our audience has had a good overview of dementia, a very serious topic, but one that we hope that you've appreciated learning about. Thank you again for joining us on 30 Medical Minutes.